Welcome to the Hospital Medicine Unplugged podcast. Today, we're undertaking really a critical, comprehensive deep dive into hyperphosphatemia management. We're focusing specifically on the high acuity hospitalized patient. Our mission here is to get beyond just the definition, and really arm you with the sophisticated risk stratification, the diagnostic algorithms, and importantly, the evidence-based repletion protocols you need. All necessary to manage this critical, yet frankly frequently missed electrolyte disorder.
Yeah, and it's a deep dive we absolutely must take because the scale of this problem is, well, it's enormous. While many clinicians maybe only think of hypophosphatemia in the context of, say, refeeding syndrome or DKA, its true prevalence in the acute care setting is just much, much higher.
Right.
We defined it simply enough. Serum phosphate level below 2.5 milligrams per deciliter. But the numbers for the critically ill are startling.
They really are.
Prevalence rates could hit, up to 75% in intensive care unit population?
75%.
Yeah, that level of incidence means we just cannot afford to treat this as an occasional problem. It's systemic to critical illness.
75% is absolutely a clinical red flag. I mean, if we're looking at 3/4 of our sickest patients potentially harboring this, risk stratification becomes just paramount. So let's quickly set the stage, maybe clarify this severity classification, because that really dictates our immediate intervention strategy.
Okay, sure. We rely on the established 3-tier classification. Mild hypophosphatemia is 2.0 to 2.5 milligrams per deciliter. Moderate disease, which often warrants intervention even if the patient's asymptomatic, that's 1.0 to 1.9 milligrams per deciliter.
Okay.
And then we have severe hypophosphatemia. This is where the risk of catastrophic complications truly escalates, defined as anything less than 1.0 milligrams per deciliter. And the clinical hook is, like you said, the systemic consequences. They are far from benign. Think acute respiratory failure, profound cardiac dysfunction, metabolic encephalopathy.
Which just means we have to be actively monitoring patients we identify as being at risk. But, to truly appreciate the urgency, we really need to understand why. Why can a simple electrolyte drop cause multi-system organ failure? Let's unpack the pathophysiologic foundation, those essential roles of phosphate.
Right. So the foundational role is cellular energy. Phosphate is absolutely critical for producing adenosine triphosphate, or ATP. ATP is, the primary energy currency for literally every cell in the body. So when phosphate levels drop severely, ATP synthesis gets impaired. This directly leads to an immediate decrease in available energy for things like active transport systems, the crucial sodium-potassium ATPase pump, and for contractile proteins. So this lack of energy directly manifests as muscle weakness and widespread organ dysfunction. The cells are literally running on empty.
Okay, so if phosphate depletion starves the cells of ATP, that explains the loss of contractility, not just skeletal muscle, but in the myocardium too, right?
Exactly.
But the mechanism connecting low phosphate to respiratory failure, that involves a separate pathway, something about oxygen delivery.
Precisely, and this is one of the most critical and honestly often misunderstood links. Phosphate is required for synthesizing 2.3-bisphosphoglycerate, or 2,3-DPG, that resides inside red blood cells.
Okay.
Now, when severe hypophosphatemia reduces 2,3-DPG synthesis, the hemoglobin molecule's affinity for oxygen actually increases. This causes a significant leftward shift in the oxyhemoglobin dissociation curve. Basically, the hemoglobin holds onto oxygen more tightly. It's less willing to release it to peripheral tissues.
Which results in profound system-wide tissue hypoxia, even if the patient's PaO2 looks okay on an arterial blood gas.
Exactly right. So you get this double physiological insult. Tissues are starved of oxygen, the muscles are starved of ATP. This is why respiratory muscle weakness, that's the ATP issue, combined with the tissue hypoxia, the 2,3-DPG issue, creates such a high risk. High risk of ventilator dependency and acute respiratory failure.
And beyond energy and oxygen, phosphate also plays a vital structural role, affecting membrane integrity.
It does. Phosphate is an indispensable component of phospholipids. Those are the building blocks of every single cell membrane. So when phosphate levels are deficient, cell membrane integrity is compromised. The most dramatic clinical manifestation of this is hemolysis, the breakdown of red blood cells, which leads to hemolytic anemia. But we also see functional defects in other cells, specifically leukocyte and platelet dysfunction. And unfortunately, that translates to an increased risk of infection and potential bleeding complications for our already very sick patients.
That really sets the foundation for the dire consequences. Okay, so now let's shift to the how. The 3 primary mechanisms leading to hypophosphatemia in the hospital setting. And these often occur simultaneously, right?
They often do. The first mechanism is internal redistribution. This involves an acute shift of phosphate from the serum, the extracellular space, into the cells, the intracellular space. This is fundamentally a process driven by metabolic demand. The classic and dangerous example is refeeding syndrome, where the sudden introduction of glucose and protein triggers this massive insulin release. Insulin drives phosphate, along with potassium and magnesium, rapidly into the cells for glycogen, protein, and ATP synthesis. The serum level just drops precipitously, reflects an acute shift, not really a true change in total body store at that exact moment.
And we see that same rapid shift mechanism in non-nutritional contexts too, which is just crucial for ICU recognition.
We absolutely do. Any aggressive insulin therapy or, large bolus glucose infusion, like what's commonly used during diabetic ketoacidosis, DKA, recovery, will induce this shift. The other major ICU driver is respiratory alkalosis. Hyperventilation, whether it's due to mechanical ventilation or a primary process like sepsis, causes the extracellular pH to rise.
Okay.
This alkalosis stimulates glycolysis and the phosphofructokinase enzyme, consuming intracellular phosphate more rapidly and driving more phosphate into the cell, acutely lowering the serum level. So understanding the acid B status is therefore really critical to understanding the mechanism.
Okay, moving to the second mechanism then. Decreased intake or absorption. This often points toward more chronic underlying issues that maybe are only unmasked upon acute hospitalization.
Absolutely. Think about patients with chronic alcoholism, those suffering from chronic malnutrition, or maybe individuals with severe vitamin D deficiency. But clinicians also must look really carefully at the medication list, particularly for iatrogenic causes, like the chronic use of phosphate-binding antacids containing aluminum or calcium, or even chronic use of dedicated phosphate binders like sevelamer, which are designed specifically to reduce intestinal absorption.
Right. And the final primary mechanism is increased losses, typically involving the GI tract, or maybe more commonly and relevant for us, renal wasting.
Renal phosphate wasting is key here. This occurs when the proximal renal tubules fail to adequately reabsorb filtered phosphate. It can be induced by concurrent magnesium deficiency, which impairs tubular function, or conditions like hyperparathyroidism, where excess PTH inhibits phosphate reabsorption. We also see this loss with specific medications, including loop diuretics, high-dose corticosteroids, and several chemotherapeutics, notably cisplatin. This mechanism is the one we really have to delineate using lab studies.
That context brings us perfectly to risk stratification. Knowing the mechanisms allows us to identify those high-risk populations where we should probably be checking phosphate levels, maybe multiple times a day.
Yeah, the critically ill or ICU patient absolutely tops that list. With up to 75% prevalence, it's almost always a combination of factors. Renal phosphate loss, often exacerbated by catecholamine surges from sepsis, acute renal injury, and that mechanical ventilation-induced respiratory alkalosis we just discussed.
Okay. And the patient presenting with alcohol use disorder, that's another prime candidate where the problem is almost guaranteed to be multifactorial? Oh, absolutely. Their physiology is it's a setup for failure. They often have poor dietary intake chronically, complicated by GI losses from vomiting or chronic diarrhea, and years of consumption can induce renal tubular dysfunction. Critically, these patients frequently present with profound concurrent hypomagnesemia. And as we'll discuss later, you simply cannot correct phosphate if you haven't corrected the magnesium.
Right.
Because low magnesium causes persistent renal potassium and phosphate wasting. Then, when they get hospitalized and are given routine IV fluids containing glucose, or maybe they require insulin, that acute intracellular shift exacerbates their deficit profoundly.
And refeeding syndrome. It's the most dramatic, potentially life-threatening cause.
Yeah.
We teach the basic concept, but clinicians really need to understand how to quantify the risk before starting feeding. Yes, it is the ultimate diagnostic challenge because it is preventable, but it's catastrophic if missed. It arises when nutritional support is started too quickly in patients who are severely malnourished, or maybe those with minimal or no intake for over 5 days. To standardize risk stratification, guidelines like the NICE criteria or the ASPEN guidelines emphasize identifying these high-risk patients. For example, a patient with a BMI below 16 or a history of significant unintentional weight loss combined with minimal intake that flags them as extremely high risk.
Okay.
For these patients, nutritional repletion, whether it's enteral or parenteral, must be initiated gradually, often starting at only 10 kilocalories per kilogram per day, with aggressive, around-the-clock monitoring of phosphate, potassium, and magnesium.
So the key isn't just knowing the syndrome exists, but knowing those high-risk criteria to proactively implement a slow feed protocol. Got it. Following that, DKA recovery is another common clinical setup for profound shifting.
Correct. The total body phosphate store in a DKA patient is typically severely depleted. That's due to osmotic diuresis and the shift caused by acidosis. However, the serum phosphate often appears deceptively normal or maybe only slightly low on admission. The profound drop, sometimes plunging below 1.0 milligram per deciliter, only occurs once we aggressively start insulin and correct the acidosis. The cellular machinery just kicks back into gear, demanding phosphate, and the serum level plummets as the deficit is unmasked. Proactive repletion is pretty standard in this setting.
And we also need to maintain awareness in the post-surgical population, too.
Yes, severe hypophosphatemia is particularly noted after major surgical procedures, especially major hepatic resection, where there are tremendous fluid shifts and increased metabolic demands during liver regeneration. Patients undergoing cryosurgery or receiving massive transfusions are also at risk for redistribution and increased renal losses post-injury. The trauma patient, similarly, is prone to catecholamine surges and subsequent renal wasting.
All right, let's move to the what? The clinical manifestations. If we miss this in a high-risk patient, what are the organ systems that are going to sound the alarm? Starting with the neuromuscular system.
This is usually where we see the first clear signs. Patients often present with generalized proximal muscle weakness, difficulty getting out of a chair maybe, or lifting their arms. But the severe manifestation we are constantly trying to prevent is respiratory muscle weakness. Impaired diaphragmatic function due to lack of ATP makes weaning off the ventilator extremely difficult. It's a leading cause of acute respiratory failure in these patients, and this weakness can manifest suddenly.
And the more drastic symptom, rhabdomyolysis, how does that fit in?
Rhabdomyolysis, that severe muscle breakdown leading to high creatine kinase levels, is particularly associated with chronic alcohol use disorder, especially following an acute drop in plasma phosphate. The exact mechanism involves ATP depletion, severely compromising muscle cell integrity, leading to necrosis. Recognizing it requires immediate intervention to mitigate subsequent acute kidney injury from pigment nephropathy.
Okay. And for the neurologic system, we see a whole spectrum, which honestly can easily be mistaken for other ICU pathologies.
That's absolutely right. It can range from subtle symptoms like paresthesias, maybe mild confusion, or gait ataxia, which can be easily attributed to sedation or sepsis. But as the level drops severely, we start seeing profound central nervous system manifestations: seizures, metabolic encephalopathy, and ultimately coma. This is directly related to impaired ATP synthesis in neuronal cells. The critical takeaway here is that, unlike some electrolyte disturbances, these neurologic symptoms often show rapid and dramatic improvement upon timely phosphate repletion, so correction is highly rewarding clinically.
Shifting to the cardiovascular system, how does phosphate impact cardiac function?
Well, given the heart is such a high divide muscle, it's highly sensitive to ATP failure. Hypophosphatemia leads to decreased myocardial contractility, a negative inotropic effect which just worsens any underlying heart failure or hemodynamic instability. Furthermore, due to complex membrane stabilization issues, it is associated with various arrhythmias. This contributes significantly to a patient's overall hemodynamic instability and potentially the risk of sudden cardiac death.
In rounding out the multi-system involvement, the hematologic system consequences, tied back to that 2,3-DPG we discussed earlier.
Yeah, we should reiterate the risk of hemolytic anemia. The combination of impaired red cell membrane integrity and the severe reduction in 2,3-DPG compromises the entire oxygen carrying and delivery infrastructure. The resulting tissue hypoxia further drives organ dysfunction. We also observe leukocyte dysfunction, which impairs phagocytosis and increases the patient's susceptibility to infections, alongside platelet dysfunction that can complicate coagulation.
Before moving to the diagnostic phase, let's just be brutally honest about the practical reality of inpatient medicine. The high prevalence of coexisting electrolyte issues. This happens all the time.
It's not just an association, it's often an underlying mechanism. Hypophosphatemia is frequently bundled with hypokalemia, low potassium, and most importantly, hypomagnesemia. These shared deficiencies, common in malnutrition, chronic alcoholism, and volume-depleted states, they create a clinical conundrum. Specifically, if a patient has refractory hypophosphatemia, meaning you're giving them phosphate, but the serum level just isn't rising, the critical missing link is almost always magnesium.
Right.
And magnesium deficiency causes renal potassium and phosphate wasting, meaning the kidneys literally cannot conserve these electrolytes until the magnesium is normalized. You must correct the magnesium and potassium deficiencies first to make the phosphate repletion stick.
That's a crucial clinical nugget. Don't just chase the phosphate if the magnesium is critically low. Okay, this brings us nicely to the systematic diagnostic approach. We need to move beyond simply confirming the low phosphate level to determining the mechanism. Is the loss coming out the gut, or is it being dumped by the kidneys?
Right. The initial assessment is fairly standard. Confirm the serum phosphate is less than 2.5 milligrams per deciliter. Then a meticulous history is absolutely essential, focusing on antacid use, alcohol intake, nutritional status changes, recent surgery, things like that. We also need immediate concurrent lab checks for potassium, magnesium, and calcium. And, critically, assess acid-base status. An arterial or venous blood gas to check the pH and PaCO2 is necessary to rule out a primary respiratory alkalosis as the driver of an acute shift.
Okay, so if the level is moderate to severe, or it's persistent, or just unexplained by obvious redistribution or intake issues, we then transition to the definitive step, determining if the mechanism is renal or non-renal wasting using urinary phosphate studies.
Exactly. This step distinguishes the proximal tubular problem from the GI or shift problem. We calculate the fractional excretion of phosphate, or FePO4, or sometimes measure a 24-hour urine phosphate collection. The interpretation here is really key for diagnosis. If the kidneys are appropriately trying to conserve phosphate, which is the expected response to low serum levels, the FePO4 should be appropriately low, typically less than 5%. This suggests the cause is non-renal, likely redistribution, like in refeeding or decreased absorption.
So conversely, if the patient has severe hypophosphatemia, yet the FePO4 is high, say above 15%, that indicates a significant persistent renal tubular leak.
Precisely. A high FePO4 signals true renal wasting. That demands a search for primary tubular defects, hyperparathyroidism, or exposure to drug toxins like cisplatin. This is the diagnostic fork in the road.
And for the really chronic or highly unexplained cases, maybe those presenting with bone pain or persistent muscle weakness, hormonal assessment becomes necessary then.
Yeah, this moves into the realm of more rare inherited or acquired causes. We'd measure parathyroid hormone, PTH, vitamin D metabolites, and potentially intact fibroblast growth factor 23, or FGF23. These assessments help us pinpoint conditions that cause chronic renal phosphate wasting.
Let's maybe dedicate a little time to the critical differential diagnoses that demand this specialized hormonal workup, starting with the context-driven diagnosis of refeeding syndrome.
Right, refeeding syndrome remains fundamentally context-driven, initiating nutrition in a starved patient. The clinical hallmarks, though, include not just those rapid, severe electrolyte shifts, the plummeting phosphate, potassium, and magnesium, but also the sudden development of fluid retention, generalized edema, and the life-threatening complications of cardiac or respiratory failure, usually within the first few days of repletion.
Okay. And the two diagnoses that often require the FGF23 and localization studies?
First, tumor-induced osteomalacia, or TIO. This is a rare paraneoplastic syndrome. It presents with chronic, debilitating bone pain and fractures, coupled with profound hypophosphatemia. It's caused by a small, often benign tumor that secretes massive amounts of FGF23. FGF23 is a hormone that causes phosphaturia renal phosphate wasting, and it also inhibits vitamin D activation. The diagnosis is confirmed by finding an elevated FGF23 level and then, the hard part, localizing the small tumor. That can be challenging, often requiring sophisticated imaging like somatostatin receptor scintigraphy.
And the other one, often seen in the surgical intensive care unit following endocrine surgery, Hungry bone syndrome.
Yes. Hungry bone syndrome typically occurs following the removal of an overactive parathyroid gland, a parathyroidectomy, or sometimes after a total thyroidectomy. It reflects a rapid, overwhelming hunger of the bone for minerals. The rapid decline in PTH causes a dramatic shift of calcium, phosphate, and magnesium into the bone matrix. This leads to severe, prolonged hypophosphatemia and hypocalcemia. It's a very context-specific diagnosis, requiring higher than normal doses of calcium and phosphate repletion, sometimes for days or even weeks.
That systematic diagnostic process is really the key to appropriate management. Okay, so once we understand the mechanism, we move to treatment. The core principle must be individualized, right? Focusing on treating the underlying cause, stopping a drug, slowing a feed rate, correcting magnesium, and then safely replacing the phosphate.
Exactly. Treatment is generally indicated for moderate to severe hypophosphatemia. So, less than 2 milligrams per deciliter, any symptomatic patient, or any patient with a high risk for impending complications, like someone about to be weaned off a ventilator. We have to be proactive in these high-risk scenarios.
Let's discuss the preferred route then. Oral or enteral replacement seems heavily favored for non-severe asymptomatic cases. That feels like a major practice point, often overlooked in the rush of acute care.
It is absolutely the preferred route, and the data supporting this preference is strong now. Recent randomized non-inferiority trials have shown convincingly that enteral replacement is non-inferior to IV therapy in terms of efficacy and time to correction for mild to moderate cases.
That's great.
Plus, it offers significantly lower cost and reduced risk of the serious complications associated with IV administration. Typical oral dosing runs from 30 to 80 millimoles per day in divided doses, often using prescription liquids or powders. It's also worth remembering that something as simple as milk, a common hospital beverage, provides a pretty good baseline. It contributes approximately 35 millimoles per liter of phosphorus.
So in the absence of GI tract issues or severe symptoms, our standard of care should really default to the enteral route. Okay, so intravenous replacement is then reserved strictly for the sickest patients.
Correct. IV phosphate is reserved for true severe hypophosphatemia, less than 1 milligram per deciliter, or for patients with acute life-threatening symptoms. Things like evolving respiratory failure, frank rhabdomyolysis, or symptomatic hemolysis.
Okay, when we administer IV phosphate, we're often using weight and severity-based protocols, maybe starting around 0.5 millicols per kilogram. But here's where we need to dive into the nuance. We have a choice between phosphate salts. Which one do we choose? And maybe more importantly, how fast is safe?
Right. The choice of salt, sodium phosphate versus potassium phosphate, is governed entirely by the patient's concurrent potassium level. If the patient is already hypokalemic, low potassium, we should opt for potassium phosphate. If the patient is hyperkalemic, high potassium, or maybe has normal potassium, and we're wary of raising it further, sodium phosphate is the clear choice. We just have to be mindful of the large electrolyte load accompanying the phosphate, whichever we choose.
Okay. And regarding safety and infusion rates, what does the evidence support for rapid correction? Can we push it?
Well, studies suggest that rapid IV administration is generally safe, provided two conditions are met. The patient has preserved renal function, and their baseline potassium level is less than 4 millimoles per liter. Infusion rates of up to 10 millimoles per hour have been shown to be both safe and effective for rapid correction in that context. However, given the risk of hypocalcemia and hyperphosphatemia, the total daily dose should generally not exceed 90 millimoles. That 90 millimoles ceiling exists to mitigate the risk of exceeding the renal threshold and causing acute, dangerous complications.
That brings up the critical safety alerts. For the hospital physicians managing these doses, what are the primary risks we must vigilantly monitor during IV infusion?
The main risks really stem from the rapid osmotic and chemical effects. We have to vigilantly monitor for two major complications. First, hypocalcemia. When phosphate is infused rapidly, it precipitates calcium, leading to a rapid drop in ionized calcium that can cause tetany or dangerous arrhythmias. Second, hyperkalemia, especially when using potassium phosphate, or really in any patient with impaired renal function, where the lack of clearance quickly leads to high potassium levels.
And this leads directly to the question of dose adjustment based on renal function. How should we modify our protocols for patients with chronic kidney disease or acute kidney injury?
Dose adjustment is absolutely mandatory. Impaired renal clearance significantly increases the risk of hyperphosphatemia, metastatic calcification, and worsening hypocalcemia. While protocols vary, a general rule of thumb for patients with a GFR less than 30 milliliters per minute is probably to initiate therapy at about 50% of the calculated dose and then assess the response very frequently, maybe every 4 hours. For patients on dialysis, consulting with nephrology and usually giving the dose during or immediately post-dialysis is typically required.
Now, let's return to that clinical reality of refractory hypophosphatemia. When you've dosed appropriately, maybe even aggressively, but the level just won't budge.
Yes. This is the most frustrating clinical scenario, isn't it? And almost invariably, the patient has an uncorrected concurrent electrolyte abnormality, usually severe hypomagnesemia. The mechanism is rooted in the renal tubule. Magnesium deficiency impairs the function of specific channels in the thick ascending limb and distal tubule. This leads to persistent renal wasting of both potassium and phosphate. You can flood the system with phosphate, but the kidneys will just keep excreting it until the magnesium level is normalized. Correction of magnesium is an absolute prerequisite for achieving phosphate homeostasis. It just won't stick otherwise.
Okay, must fix the magnesium. So we have to move seamlessly into the final phases of care, the monitoring protocol and the prognosis. For a patient on IV repletion for severe hypophosphatemia, how frequent is frequent enough for lab checks?
Well, for any critically ill patient, daily monitoring of a full electrolyte panel is necessary baseline. However, during active intravenous repletion for severe cases, levels below 1.0 milligram per deciliter serum phosphate must be checked, I'd say, every 4 to 8 hours. The goal is to rapidly bring the level above that critical threshold, monitor closely for rebound hypocalcemia or hyperkalemia, and then transition the patient to a safer, sustained oral or enteral maintenance dose as soon as the patient is able. And this monitoring requires that full panel we discussed, not just checking the phosphate in isolation. Absolutely. Concurrent monitoring of calcium, magnesium, and potassium is required, precisely because of the risks of precipitation and that critical need to address refractory states driven by low magnesium. We should also stress that protocol-driven approaches which standardize both the risks stratification and the dosing monitoring frequency have been shown in major hospital studies to significantly improve the rate of normalization and actually reduce complication rates. Having a protocol helps.
Definitely. Okay, let's conclude with the prognosis and outcomes. What does the evidence really tell us about the significance of low phosphate? Is it just an innocent bystander, or is it truly a marker of severe disease?
Oh, it is overwhelmingly a marker of greater overall illness severity. Hypophosphatemia is consistently associated with longer hospital stays, increased morbidity, higher usage of mechanical ventilation. The list goes on. Multiple large retrospective and prospective studies have documented a strong association between low phosphate on admission, even in the mild range, and significantly prolonged hospital stays. Furthermore, some observational data suggest maybe even a threefold increase in adjusted in-hospital mortality when phosphate levels are critically low. It is without question a clinical red flag indicating a high-risk patient population.
That strong association is clear. But this brings us to the crucial evidence gap, the one that really informs our clinical decision-making day-to-day. Does phosphate repletion itself reliably improve those hard outcomes like mortality and lengths of stay?
That is the million-dollar question in the literature, isn't it? While severe hypophosphatemia certainly precipitates fatal outcomes, acute respiratory or cardiac failure, for instance, the high-quality evidence linking phosphate repletion directly to improved hard outcomes, like overall mortality or reduced length of stay, especially in non-symptomatic moderate cases. Well, it's surprisingly limited.
Really?
Yeah. Most studies demonstrating benefit focus on surrogate markers, or they're retrospective. We lack definitive, large-scale, randomized controlled trials proving that aggressively correcting a moderate, asymptomatic deficit actually changes the ultimate outcome.
That's where it gets really interesting and maybe a bit challenging for the practicing hospitalist. We have a clear mandate to treat the underlying cause and aggressively correct the symptomatic patient to prevent catastrophic failure.
Exactly. And our management protocols reflect that. We treat the severe and the symptomatic aggressively. We favor the evidence-supported enteral route when possible for all others. We've established that hypophosphatemia is a critical multifactorial problem in hospitalized patients. It's driven by redistribution, decreased intake, renal losses, and management requires a systematic approach.
And as a final synthesis, it's crucial to remember that the serum phosphate concentration is only an acute measurement. It often does not accurately reflect the total body phosphate stores, particularly in acute illness where intracellular shifting is the primary driver. We just have to look beyond that single number to the full clinical context, the acid-base status, everything.
Which leaves us with maybe a provocative thought for you to carry into your practice. Given the strong correlation between low phosphate and high morbidity, but acknowledging the current evidence gaps regarding correction of asymptomatic moderate deficits, how should you ethically and practically balance aggressive phosphate repletion, aiming to prevent immediate symptomatic complications like respiratory failure, against the lack of high-quality randomized data proving improved long-term hard outcomes in those non-symptomatic moderate cases? It requires continuous clinical judgment, I think, always erring on the side of preventing life-threatening respiratory or cardiac compromise.